to this first ever one-day national webinar with the theme of Ilmul Jaraht Updates 2022. Am I audible?
Yes.
Respected director, sir, teachers, guests, seniors, colleagues, and my dear students, I am Dr. Firdaus Ahmad Najjar, Assistant Professor, Department of Ilmul Jarahat. As convener of this today's program, I have with me Dr. Muhammad Shakil Ansari, Dr. Majabin Fatima, Assistant Professors of the department as organizing secretaries of this program. Professor Shah Alam Sahab, HOD Ilmul Jarahat, is heading the program as Chairman Organizing Committee under the patronage of our Director, Sir Professor Ilmul sir. We are celebrating 75th year of independence of India as Azadi Ka Amrit Mahotsav. Today's program is a part of the same celebration. Our program will be as first, there will be welcome address, followed by address of the director, sir. Then there will be brief introduction of the Department of Ilmul Jarahat, NIM Aligarh. Then followed by 2 lectures. After every lecture, enough time will be given to the participants to interact with the speakers. So I request the participants to mute themselves till the lecture will end. And e-certificates will be sent to each participant after submitting their feedback form, which will be sent to them soon after the end of this program. The last, there will be vote of thanks. Most of the guests, most of the participants have joined us. I will take this opportunity to welcome all guests and participants here. I, on behalf of the organizing committee of this one-day national webinar, welcome our director, sir, and patron of this today's program, Professor Abdul Wadud, sir. He, despite being busy, he managed to join us and encourage us. So I welcome you from on behalf of the department.
Thank you.
I welcome our guest speaker, our mentor, teacher, Professor Iqbal Aziz, sir, Chairman, Department of Jarahat, Ajmal Khan Tibiya College, Aligarh Muslim University. Sir, I welcome you on behalf of the organizing committee. I also welcome my teachers, my seniors, colleagues, and students who have joined us. I am thankful to you all that you have managed your time to join us and encourage us. Hope today's webinar will be fruitful and will expand our knowledge by different aspects. Before proceeding ahead, I will request Director, sir, to address the audience. Director, our Director, Professor Abdul Wadud, sir.
Assalamu alaikum. A very good morning to all of you. Respected Professor Iqbal Aziz Sahab, Dr. Sayyid Shah Alam Sahab, Dr. Firdaus Ahmad Najjar, Dr. Shakil Ahmad Ansari, Muhammad Shakil Ansari, and Dr. Majabin Fatima, and all other participants. ये हमारे लिए बहुत खुशी का मकाम है कि गवर्नमेंट ऑफ इंडिया का जो प्रोग्राम है आज़ादी का अमृत महोत्सव, उसके तहत नेशनल इंस्टीट्यूट ऑफ यूनानी मेडिसिन में प्रोग्राम्स की एक सीरीज़ जारी है, जिसका एक हिस्सा वेबिनार भी है। अभी कल एक नेशनल सेमिनार भी हुआ है जो फिजिकल हुआ था। ज़्यादातर शुरका नेशनल इंस्टीट्यूट ऑफ यूनानी मेडिसिन के बारे में जानते हैं। NIM के बारे में मज़ीद तफसीलात फराहम करना अब ये वक्त की ज़रूरत नहीं है और न ही इसका वक्त है। मैं बहुत बहुत शुक्रगुजार हूँ प्रोफेसर इकबाल अजीज़ साहब का कि उन्होंने हमें मौका दिया और पार्टिसिपेंट को एड्रेस करने के लिए उन्होंने वक्त निकाला। डिपार्टमेंट ऑफ इल्मुल जराहत नेशनल इंस्टीट्यूट ऑफ यूनानी मेडिसिन का एक बहुत ही प्रेस्टिजियस डिपार्टमेंट है और प्रोफेसर सैयद शाह आलम और उनकी टीम इस बात के लिए मुबारकबाद की मुस्तहिक है कि इन लोगों ने डिपार्टमेंट को एक शेप दिया है जो कुछ सालों पहले नहीं था। अल्हम्दुलिल्लाह इस डिपार्टमेंट में अलीगढ़ की तर्ज पे और भी दूसरे जो सर्जरी डिपार्टमेंट है उनकी तर्ज पे बेहतरीन काम हो रहे हैं। यहाँ पे सर्जरीज भी हो रही हैं और
हाँ क्योंकि पार्टिसिपेट
सैयद शाह आलम साहब और उनकी टीम डिपार्टमेंट को न सिर्फ बल्कि ऑपरेशन थिएटर को एक स्टेट ऑफ आर्ट थिएटर बनाने में मसरूफ है। इंस्टीट्यूट की तरफ से उनको हर किस्म की एड फराहम की जाएगी जितना वो चाहेंगे इस डिपार्टमेंट को मजीद तरक्की दे सकते हैं और आगे ले जा सकते हैं। वेबिनार की इस सीरीज में इस बात की खुशी है कि उन्होंने एक बहुत ही ख़ास टॉपिक चुना है और बहुत बड़ा वेबिनार नहीं रखा है। एक मुख्तसर सा टॉपिक है, गालिबन लेप्रोस्कोपिक सर्जरी और लेप्रोस्कोप के बारे में वो इस वेबिनार में तफसील से बात की जाएगी। ज़रूरत इस बात की है कि छोटी छोटी चीज़ों पे जो यूनानी के तलबा ख़ास तौर से जो सर्जरी डिपार्टमेंट में है और दीगर डिपार्टमेंट में भी हैं, उनको इन चीज़ों के बारे में मालूमात वक्तन फ़वक्तन हासिल होती रहे। सर्जरी के अंदर कोई भी नया इन्वेंशन आता है, कोई भी नई टेक्निक आती है, तो ज़रूरत इस बात की है कि तलबा को इन बातों से आगाह किया जाता रहा है। मेरा ख्याल है कि इसी पस मंज़र में उन्होंने इस टॉपिक को चुना है क्योंकि यहाँ पर एक लेप्रोस्कोपिक सर्जरी भी अल्हम्दुलिल्लाह बाकायदा होती है, लेप्रोस्कोप भी मौजूद है। तो मैं इन्हीं चंद बातों के साथ अपनी बातों को ख़त्म करना चाहूँगा क्योंकि ज़्यादा से ज़्यादा वक्त मुक़र्रिरीन को मिलना चाहिए और शुरका उससे मुस्तफ़ीद हों। शुक्रिया, खुदा हाफिज़।
Thank you, sir. Thank you, sir. Thank you, sir, for your encouraging words. With your permission and with the permission of the chairman organizing committee, I will give a brief introduction of the Department of Ilmul, Jarahat, and Bangalore.
Please
The department was started in 2012 with the appointment of 3 faculty members. Later, after 2 years, one more faculty member was appointed. We started with OPD and IPD and minor cases and local anesthesia with 2 to 5 cases per week at that time. Admission of the first batch of students was permitted by the then CCM in 2014. Right now, we have 4 faculty members with 1 on-call basis surgeon and 1 on-call basis anesthetist. Alhamdulillah till date, 5 batches have completed their post-graduation successfully, who are well situated with the art of surgery and are serving in the different parts of the country, either in the teaching institutions, or in the periphery, or in different hospital setups. We have taken research on different surgical ailments like non-healing ulcer, colorectal diseases, renal stones, etc. By the grace of Almighty, we have been successful in developing a state-of-art operation theatre here in NIM Hospital with all higher-end equipments. Right now, we have 4 operation tables, higher-end laparoscopic setup, harmonic, pottery, and a state-of-art sterilization unit. Alhamdulillah, we are now well equipped to perform all major surgeries also. Now the number has crossed in thousands per year, means we are now performing thousands of surgeries per year. Our next goal is to set up an ICU for which work is already in progress. And Director Sir had already told that he will surely cooperate in this, and his cooperation has been there in past also. Dear audience, due to shortage of time, I will not go into details, more details about the department. I will end up here. that all this is a collective effort of the faculty members of Department of Ilmul Jarahat under the guidance of our HOD, Professor Saeed Shah Alam Sahab, with the cooperation of our Director of. Now I'll come back to today's program, one-day national webinar with the theme of Ilmul Jarahat Update 2022. As all you know that paradigm of general surgery is changing, or I may say it has changed now from open surgeries to minimal access surgeries, minimal access procedures, that is laparoscopic procedures. Because these minimal access procedures offer significant advantage for patients in many ways, like minimal trauma, early mobilization, and less hospital stay. Today's seminar will throw light on these procedures, on laparoscopic procedures, which consists of 2 lectures on minimal access surgery. First lecture will be laparoscopic procedures, followed by second lecture, the instruments used during laparoscopic procedures. Our first speaker, our teacher, mentor, Professor Iqbal Aziz sir will deliver a talk on laparoscopic procedures in surgery. I will introduce Iqbal Aziz sir to the participants, although he is well known to everyone, but still I would like to introduce Iqbal Aziz sir. Iqbal Aziz sir is Chairman, Department of Jarahat, Ajmal Khan Tibia College, AMU Aligarh. He has done his MBBS and MS from Jawaharlal Nehru Medical College, Aligarh. He joined Ajmal Khan Tibia College in 1993. Since then, he is actively engaged in teaching, training, and research activities of the department. He has published many papers in national and international reputed journals. He has attended and presented papers in about 50 national and international conferences across the country. He is life member of Association of Surgeons of India. He is founder member of Association of Minimal Access Surgeries of India. He is member of Indian Hernia Society also. Moreover, he has done many clinical trials on Unani medicine also. And last but not the least, his area of interest is laparoscopic surgery. So with these words, I will like to invite Professor Iqbal Aziz sir, sir, to start his talk today. Professor Iqbal Aziz sir.
Assalamu alaikum, everybody.
Walaikum salam, sir.
I am thankful to the organizing team and the director and the chairman Department of Surgery, NIUM, for inviting me to give a lecture on the laparoscopic procedures, which is an hour of need. Nowadays, everybody is talking of laparoscopic procedure. And basically, all open surgical procedures has been converted or nowadays are being done by laparoscopically instead of doing an open surgery. Some difficulty opening the screen. I'll share.
You share your screen, sir.
Yes, I'm trying to do it. स्क्रीन काम भी अभी करके देखा है। कहाँ था वो, कैसे शेयर किया था?
इसी में 10 नहीं आ सकते हैं।
हाँ, फिर नहीं आ रहा। ये हेलो,
जी सर।
हाँ, ये जो शेयरिंग का, स्क्रीन शेयर का था ऑप्शन, वहां से खत्म किया है क्या? क्योंकि
नहीं,
अभी मैं, क्योंकि
हाँ,
यहाँ से
मैडम,
शेयर,
यहाँ से परमिशन, हाँ,
यहाँ से शेयर नहीं हो रहा है, वो दिखा नहीं रहा है।
फिरदौस साहब आप कुबरा से बात कीजिए, कुबरा से।
मैं जी कर रहा हूँ। क्या कह रही मैडम? हाँ, यहाँ से प्रॉब्लम नहीं है सर,
हाँ,
यहाँ से परमिशन है सर, और कोई भी जो है स्क्रीन शेयर कर सकते हैं।
हाँ, क्योंकि इससे
सर, ये
पहले
green
मैं,
आपके पास शेन्स, आप उनकी बात करिए। मेल कर दो ना इसको, मेरे नजदीक से पूछ दो। उनका नाम आने के बाद नहीं, नीचे आ रहा हो करना है, शेयर करना
नहीं, वहां से आ रहा है स्क्रीन शेयर, लेकिन यहाँ से हो नहीं रहा है।
अप्रैल का मंथ। तो आप जो है ना इनको इससे कर दीजिए सर,
इसे क्या शेयर, ये शेयर करके देखो।
तब करेंगे जब
हाँ?
चीजें हम कुछ सिलेक्ट करेंगे, जो चीजें वो सिलेक्ट करेंगे वो तो शो ही नहीं करेंगे। बात ये है।
वसीम स्क्रीन शेयर क्यों नहीं हो रहा है? यहाँ से टेक्निकली करेक्ट है, यहाँ से सब चीज अलाउड है।
अच्छा, चलिए देखता हूँ।
हाँ सर, आ रहा है सर।
Now it is
Alright.
showing. Now it is showing started screen sharing.
ओके,
हाँ,
Maybe possible, sir.
तो आप पीपीटी ऑन है ना सर आपका?
ये भी हो सकता है कि इंटरनेट क्वालिटी
हाँ,
कोई वो।
अभी चल रहा है, होने दो।
Yeah,
Yeah,
sir.
sir.
Come, sir. Come, sir. Very
आगे
good.
आगे।
Thank you, sir.
चलिए,
कमेंट्स में भी लिखा है आवाज कम आ रही है, मेरी आवाज कम आ रही है, कम मेरी।
जी सर,
स्क्रीन
प्लीज।
ये हटे ना। ठीक है, चलिए। ठीक है, मूव नहीं कर रहा ना ये पीपीटी मूव तो नहीं कर रहा। लेप्रोस्कोपिक प्रोसीजर ये ऊपर था ना, ये मूव नहीं कर रहा ना, मूव क्यों नहीं आ रहा, क्या हुआ?
वसीम, क्या प्रॉब्लम है?
मेरी बहन को चला गया।
सर आपको अनम्यूट करना होगा अपना। सर आपका अनम्यूट नहीं है अभी।
नहीं, वो नहीं है।
सर प्लीज अनम्यूट योरसेल्फ।
सर माइक्रोफोन को अनम्यूट कर लीजिए। अब्बास सर।
तो मेरा तो अच्छा
हाँ,
अनम्यूट कर
अब
दिया।
अब हुआ, अब हुआ, अब आ गई आवाज।
जी
हाँ, अब आ रही है आवाज सर।
हाँ, लेकिन ये स्क्रीन शेयर में पावर पॉइंट जो है ना,
जी सर।
ये स्लाइड मूव नहीं कर रही है, ये प्रॉब्लम हो रही थी।
लेकिन सर आवाज साफ आ रही है अब आपकी।
नहीं, आवाज तो साफ है। हेलो, हाँ मैं जब भी आवाज, हाँ
आवाज सर आ रही है आपकी,
अच्छा ठीक,
आवाज आ रही है सर।
ठीक है, ठीक है।
पावर पॉइंट को एक बार मिनिमाइज करके फिर से
हेलो?
मैक्सिमाइज करें, शायद आ जाए।
जी 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 बताएं। इस प्रेजेंटेशन का स्क्रीन शेयर करो, ये वहां का स्क्रीन शेयर किया है। हाँ, बैकग्राउंड की तरह इसको बंद करो और प्रेजेंटेशन का स्क्रीन शेयर करो। नहीं, ये वहां का स्क्रीन शेयर कर लिया है, देखो।
पावर पॉइंट ओपन करके उसको मिनिमाइज न किया जाए सर। पावर पॉइंट को अगर मिनिमाइज कर देंगे तो स्क्रीन शेयर ऑप्शन में वो ऑप्शन दिखेगा नहीं।
हाँ, अब
लाइट को
पावर
ओपन
पॉइंट
करके
ओपन करो। ओपन, हाँ ओपन हो गया। हाँ, दबाया। पावर पॉइंट एंड विजुअल बैकग्राउंड। अब
पावर पॉइंट ही तो है सर।
पहले ऑफ कर दो स्क्रीन शेयर, पहले ऑफ, ये ऑफ कर दो, पहले ऑफ करो, इसको भी ऑफ करो। ये क्या है? हाँ, अब स्क्रीन शेयर, अब वो पावर पॉइंट होगा। ठीक, अब ये करो। नहीं, नहीं हो रहा। अच्छा देखिए 5 मिनट दीजिए, मैं दूसरा लैपटॉप लगा के देखता हूँ। हो गया हो गया
सर,
हो गया।
चलिए चलिए, थैंक यू। ठीक है ठीक है। हेलो हेलो।
Okay, sir.
हाँ, able to hear me?
Yeah.
Sorry
Yes,
for
sir, yes, sir.
sorry for
Audible, sir. Audible.
Yes, sir, you are audible. You can start, sir.
Yes, I'm going to start now. And it's sorry for all these disturbances. This is the problem of online doing distance measurement and distance monitoring. So we are going to discuss the laparoscopic procedures. As I was talking that these laparoscopic procedures have been, all open procedures are now being replaced by laparoscopic procedures. And the laparoscopic procedure is that you do a minimal trauma to enter into the cavity, any space. For entering into the or reaching up to the viscera you want to operate through by producing a minimal damage to the coverings. But the procedure remains the same. The procedure as for example are doing a cholecystectomy. You only entering into the peritoneal cavity, you do a minimal damage to the walls. And through that, we can enter into the peritoneal cavity and do the cholecystectomy. The procedure remains the same. Myomectomy, esophageectomy, any procedure that has to be done by laparoscopically. It has got the advantage of a cosmetic advantage as well as the physical trauma to the patient. As for example, we were doing vagotomy. In that case, we have to reach up high into the just below the diaphragm as the esophageal hiatus, and there we have to mobilize the stomach, long big incision in the midline and opening up of the peritoneal cavity, and there at the esophagus you have to do the vagotomy. And nowadays with the 3-port incision, 10 mm and 5 mm incision, we can reach up to the high up to the diaphragm and do a procedure very easily. So this was now the laparoscopy, minimal invasive procedure was done long back since early 19. Then it progressed slowly. The first laparoscopic cholecystectomy in India was performed in 1990 in Bombay by Dr. T. Udwadia. Since then, it is continuing and progressing with the advancement of instruments. Initially, it was two-dimensional picture. Now, it has been done into three-dimensional picture. In two-dimensional picture, we were visualizing only length and breadth, no depth. But nowadays, we can perform a surgery in three-dimensional cameras. And we can assess the depth of the viscera. And it is easy to perform a surgery when you are able to assess the depth. How many of the surgeons who have joined are doing laparoscopy? Any idea? NIM is doing.
Yeah, we are doing, sir.
Yes, sir.
And-
NIM.
And doing in here in Aligarh we are doing. Any other places? Anybody is performing or assisting the laparoscopic surgery?
In Pune, sir, also.
Hmm?
In Pune also.
In Pune also.
They are also doing.
Yeah.
Finally, sir.
Okay,
Manzoor, sir.
so there, Manzoor sir, okay. So it is those who are performing the surgery or assisting the surgery, they are able to assess the difficulty of 2-dimensional and 3-dimensional surgery.
और ब्रेन जब किसी फैट को देखता है तो फैट पे ज्यादा सस्पेशन आता है.
Now, ये क्या आ गया बीच में? हाँ. Now, in the laparoscopic surgery, we initially divided as diagnostic procedures or the therapeutic procedures. Now, mostly nowadays the advanced studies such as CCT and the MRCP and all the advanced radiological investigations are available to assess the disease and the disease process, how much it has extended. Initially, when these advanced investigations were not available, laparoscopy was done in most of the cases when it was difficult to assess whether it is what disease process is going on. When we were the students of MS, there were hardly any ultrasound done in Aligarh. So whenever the patient was coming with the pain and doing this, and we suspected to be a peritonitis, and we have to go for the diagnostic laparotomy. We have to open the abdomen and see what is the problem, and we have to face the situation as per laparotomy finding. That's why it was, the abdomen was known to be as a magic box, that you open it and then you will see what a magic you are doing. But nowadays
जो के
it
ये
has
से
been,
दो जो है
now it has been a diagnostic laparoscopy came. We confirmed the diagnosis that this is the diagnosis, and nowadays there is no need to you make a diagnosis. You go for diagnostic laparoscopy and you do a procedure as a therapeutic procedure. It's a small, easy procedure, easy to convert into therapeutic laparoscopy. No scar, small scar, quick healing, less painful. So all these advantages of performing the laparoscopic procedures. Now we come to some therapeutic procedures, because now the situation have changed. There is an operating room setup with the equipments. We position the patient. We have a monitor on one side as per requirement of the surgeon and the procedures. Now, on one side there is surgeon, another, by the side of the surgeon is the cameraman or assistant surgeon or staff nurse, because now our eyes are the camera, and once the camera surgeon or camera person is expert, he will show you the everything, because he is your eyes. through that eyes, you see the internal things or anything, and you correlate your hand and eye movement according to the screen and camera and your instruments. So basically, the laparoscopic surgery is the hand and eye coordination. In open surgery, you don't need any coordination. Coordination is needed, but you need an extra coordination that you see at different angle and operate your instruments in different position. You have to make a coordination. So in the early stage of learning, hand-eye coordination is difficult to develop, but it depends upon the capability of the surgeon, how he coordinates himself in hand-eye coordination. Now, in the operative room setup, optimum position of equipment and team, surgeon, assistant, staff nurse, and most important is the monitors. Because if these main is the monitor and the surgeon or other staff with the monitor, they have to coordinate with the monitor, because if the monitor is not in the normal position, then we will have a strain, physical strain. So they have to be in optimum position so that there is minimal strain on the surgeon. The neck, shoulder, body, all is to be in an optimum position and relaxing position. Before we go for an operation, we should have a checklist of anesthesia equipment, electric operation table, monitors, suction, irrigation, and grounding pad. This is very important. Grounding pad, because we use the cautery to stop the bleeding as well as for dissection. If the grounding pad is not sufficiently covering the surface area, it will produce the burn. And high intensity cautery is used. In open surgery, we use very small intensity cautery. The laparoscopy, it is high intensity cautery which is used. So grounding pad is very important. Laparoscopic instruments, there has to be well, before starting the operation, we should see all our equipments that they are functional and doing work. Because if one forceps is not working, you will not be able to do the surgery. And one important thing is the X-ray unit. Performing a laparoscopic cholecystectomy, a simplest procedure nowadays is performing a laparoscopic cholecystectomy or laparoscopic appendicectomy or pyelolithotomy or different things. But if you are performing an advanced procedure such as choledochotomy or pyeloplasty, and in which you will need an X-ray unit also. And that has to be a good X-ray unit so that you will be able to delineate the structures. All the procedures in surgery nowadays are being performed laparoscopically. I have named only 3 or 4, 5, but every procedure are now being done by the laparoscopically. Whether you name any procedure, it is a matter of center where you are performing, or how much you are trained. Your training and the center at which you are performing and how much facilities you are having. Because now everybody is saying you can perform any surgery laparoscopically if you are having a training and the instruments. Because instruments are very important to be there to perform any surgery. The simplest procedures are these are the cholecystectomy is the commonest procedure is being performed, appendicectomy, hernia repair or nephrectomy, splenectomy, pyelolithotomy, adrenalectomy, colectomy, hemicolectomy, thoracic surgery, thyroid surgery, breast surgery, name any procedures. The breast surgery are also being done. All the gynecological surgeries are being performed by the laparoscopically. And nowadays the 3D. Now the cholecystectomy can be performed safely as an elective case. A very safe procedure. And in emergency also nowadays we are performing cholecystectomy in acute stage. Emergency can be performed following empyema gallbladder, mucocele of the gallbladder, Mersey syndrome, obstructive jaundice, pancreatitis, acute cholecystitis can be done. All are safe procedures are to be done laparoscopically, but in acute stage, for performing the acute condition, the adequate experience of surgeon. This is very important in performing the acute surgery in acute conditions. The surgeon is to be experienced and he should have an assistant of same caliber so that something happens, they can assist each other. And there should be low threshold for conversion. Low threshold means a surgeon should have patience. He should have to dissect patiently, not in hurriedly manner. So he should have a low threshold for conversion. And the operative table competent for radiography. And the patient, the basic requirement, the basic thing is that the patient is to be a stable patient. Not the unstable patient is to be taken up for emergency surgery. Emergency surgery, if you are doing a laparoscopically, the patient is to be well stable. Now another laparoscopic procedures are single incision laparoscopic surgery. They are the modification of the laparoscopic surgery. Nowadays a single incision is given through which a port are inserted with multiple openings, and you insert the ports with in the single incision. These are all cosmetically important. The robotic surgery, this is an advanced technique, can be performed from the distant. The patient is lying 100 miles away or 1,000 miles away, and that is governed by the robot. You perform the robotic computer on, you press the things and the surgery is performed far away, and this is very advanced. But nowadays it is a common, robotic surgery is becoming a common. Now these are the slides of gallbladder surgery, in which first step is to enter into the peritoneal cavity. then hold the fundus of the gallbladder to give a cranial retraction, that up we hold the fundus of the gallbladder and retract it up towards the diaphragm, and that gives us the view of the whole of the gallbladder as well as the neck of the gallbladder, and we can see and dissect the cystic artery, cystic duct. We give a lateral traction at the neck of the gallbladder, and we are able to see the cystic duct and the cystic artery separately. This is the dissection which is important so that we are able to see the cystic duct and cystic artery separately. When we are able to see these two structures separately, we put the clipping of the cystic duct and the cystic artery. Then we cut the cystic artery and the cystic duct, and when it is dissected, we pull out the gallbladder through the epigastric port, 10 mm, and then we remove the content of the gallbladder so that it may collapse, and then we remove the gallbladder from the peritoneal cavity. Now, this is very simplest, but we have got a videos. I'll show you the videos of the cholecystectomy which we were performing here. Let's see if they play. But these are the simple procedures. And now the second thing, if we are able to perform the cholecystectomy, and the patient is also having a common bile duct stone, we can explore it laparoscopically. At some places where the facilities of doing an ERCP is available, then people try to get the common bile duct stone removed through the ERCP. But sometimes it is so much impacted, the stone are multiple and impacted, the ERCP is not successful. So we have to explore the CBD. And it is a highly expertise procedure. Surgeon is to be expert in performing and suturing and knotting and suturing, very important part of the laparoscopic surgery, that we should know how to put the sutures and how to knot the ligature. Needs and radiological equipment so that we may see whether the CBD is clear or not clear, or patent or not patent. And it also needs, if you are doing a laparoscopic CBD exploration, we should have a facilities of choledocoscope, Dormia basket, dilators. If we are seeing a choledocoscope, we are able to 100% sure that there are no stone left or no sludge left into the hepatic ducts or intrahepatic ducts. There is nothing is left. These are the pictures in which the CBD has been opened vertically and through which the stones are extracted with the Dormia basket. Now these are the steps of the performing an appendectomy, in which we enter into the peritoneal cavity with the same umbilical port and the inferior umbilical port and the right iliac fossa port. We enter into the peritoneal cavity. We dissect the appendix and we loop it. We put the loop at the base of the appendix, and then the appendix is cut and removed from the peritoneal cavity. Now, another important aspect of laparoscopic for general surgeon, it is the hernia. Hernia repair through the laparoscope. It is a difficult surgery. Laparoscopically doing a hernia is a difficult surgery and needs a very expert hands as well as the expert anesthetist, because in performing the hernia surgery, it is a reverse Trendelenburg position in which the whole of the content of the peritoneal cavity lie on the diaphragm, and you are given a free space, because a free space is needed in performing a laparoscopic hernia, laparoscopically hernia repair. It is easy to perform bilateral hernia, because in one sitting you can put a large mesh without any cut on the bilateral side. You can put a large mesh into the peritoneal, into the hernial spaces. Now, initially the inguinal hernias were repaired intraperitoneally, and mesh was placed intraperitoneally. So nowadays there is no need to open the peritoneal cavity. You dissect the extraperitoneal space and then put the mesh after the dissection. But there are now, the teaching of anatomy has to be reversed or changed, because we were taught the inguinal anatomy from skin to downward, skin to peritoneal cavity. But nowadays the anatomy for hernia repair, or you visualize the peritoneal cavity from the peritoneum to the skin. You remove the peritoneum and the structures and the nerves and the ligaments and the muscles which you visualize is from the inside out. We were taught outside to in. Now it is the hernia anatomy is to be, or inguinal anatomy is to be taught from inside out. This is the view of the inguinal region. This is an intact peritoneum. Before reflecting the peritoneum, we have to reflect the peritoneum to put the mesh, and before reflecting the peritoneum, we visualize the things. That has to be seen in the... Now this is a hernial orifice. Here there is no hernia, no orifice is visible. the hernial orifice is visible. Now these are the, you go on discussing the procedures which you have to perform, but we have to be cautious and perform surgery with all our limitations as we are performing in our setup. You well know all surgeons who are exposed to surgery, open surgery or laparoscopic surgery, they should know their limitations before performing the surgery. Now, the troubleshooters in the laparoscopic surgery, which happens if you are having a single unit of laparoscopic setup. Some hospitals have got multiple units. They don't have to worry about the instruments or the things, monitors or insufflators. But if you are having a single setup, single set, you have to be very cautious. The poor insufflation, excessive pressure in the peritoneal cavity, inadequate light, bright light, no picture, poor quality picture, inadequate suction, absent cauterization. These all happens with us when we perform the surgery. And sometimes with these limitations, we have to convert it into the open. Thank you. Now we can see some videos and have a discussion. Somebody, if you have to ask the questions, we can discuss the procedures as well as the limitations. First of all, we should see some videos. Now, this video is of performing surgery. It's our setup video. It's not the recorded video or somewhere. It is this videos which we have recorded earlier. This is after entering into the peritoneal cavity, giving a retraction at the vertical retraction to the gallbladder, and then holding the neck of the gallbladder with the Babcock, and this Maryland forceps is dissecting the next. Now the next.
सर अस्सलाम वालेकुम सर, बीओएमएस क्या ये सर्जरी कर सकता है लेप्रोस्कोपिक, ये लीगली कहाँ तक क्या ये है, इसके बारे में सर पहले बताइए, फिर ये वीडियोस वगैरह।
सर हेलो, आप ये क्वेश्चन बाद में पूछ सकते हैं, आप लेक्चर के बाद आप पूछ सकते हैं, आपको टाइम दिया जाएगा।
अभी एक ये वीडियो देख लीजिए
सर, आप कंटिन्यू कर लीजिए सर।
हाँ, नहीं मैं कंटिन्यू कर रहा हूँ, लेकिन साथ में इनका जवाब भी थोड़ा सा दे दूं। इफ ही इज हैविंग अ क्वेरी के क्या कर सकते हैं क्या नहीं कर सकते, वी आर नॉट डिस्कसिंग दिस थिंग इन हियर, वी आर सीइंग द थिंग्स व्हिच आर बीइंग डन इन द वर्ल्ड। This is a video, the same video, उसको थोड़ा शॉर्ट करके दूसरा आगे डाला है। There is a lymph node visible and the cystic artery is visible, cystic duct is visible, and it's a dissection being done to isolate this is cystic duct, which is isolated, okay? Now the clipping of the duct. Now clipping of duct has been done. The two clips proximally. Okay. You are seeing the clips. And you are giving a lateral traction to the fundus so that you are able to dissect it and put the clip properly. Now this clip is the clipping of the duct distally so that there is no leak after cutting the duct. The cystic duct has been cut. The cystic artery has been ligated. This is the lymph node. Now the gallbladder is being separated from the bed. Fifth. See. Picture quality is not very good because it has been old recording. It is appearing to be as the old movies recording, and nowadays the HD movies are coming and the recording is HD. So it is not a very good, if you see a recorded is only to share with you the चलो सीखो आर्टरी को क्लिपिंग हो रही है। चलो नेक्स्ट कर। ये भी
दूसरी
this is the gallbladder now being separated from the bed after with the cautery and the hook. Chalo, next. Last one. And now the gallbladder has been separated and it is pulled through the epigastric port and the drain is put before. Okay, chaliye, next. और है कोई वीडियो? शेयर को देखना। पुलिस हिस्टेक्टमी, hernia. ये निकले होगी इसमें, ये इसका प्रॉब्लम है जो। और दूसरा this is hernia operating, that we are pulling down the content of the sac into the peritoneal cavity. Now this is when we perform the renal surgery, the patient in the lateral position, and because it is a retroperitoneal structure, there is no space such as in the peritoneal cavity, so that how to enter in, how to make the space, because the basic thing is that we should have a space for our instruments, movement, and to produce the air cavity so that we can move the instruments. So for creating a space in the perinephric space, we put the balloon and make an incision and put the balloon inside, that inflates or separates the tissue, so that once we enter, we create the space. Once this space has been created by inflating the balloon, balloon निकाल देते हैं, we remove the balloon and air entry is there, और तो peritoneal cavity और wall के बीच में space बन जाता है. There is a space is created, and we do the dissection to do the solid organ or retroperitoneal structures such as the pyelolithotomy or nephrectomy or adrenalectomy or a pyeloplasty. Everything can be done after creating the space. So basically, we have to create the space in the retroperitoneum by putting a balloon and then creating the space. Next. The same procedure in which you have dissecting the kidney, around the kidney fat and kidney and okay, thank you for patience listening. And this was the lecture to introduce a laparoscopy. Now it is not a new procedure; it has been an old procedure, and nowadays every general surgeon is to be trained in the laparoscopic procedures, because general surgery is not complete without laparoscopic procedures learning. You should know the open procedures as well as the laparoscopic procedures. Thank you. Any questions? I am ready to give the answers, because it is difficult to understand the procedures if you have not seen the open surgery or the laparoscopic surgery. If you are not aware of the things, it is difficult to understand the terminology we were saying. Those who are exposed to the surgical procedures, they will be able to understand the things better. Okay.
Thank you, sir. Thank you very much, sir. Thank you for your enlightening speech. We have come across new things in your lecture, sir. Like common things which we miss during the procedures. Am I audible, sir?
Yes, you are audible.
Like optimum position. The new surgeons usually don't make proper positions, and they get exhausted during the surgery and make some mistakes also during the surgery. And one query you have raised during this your lectures, whether sir, you are doing laparoscopic surgery. We have some comments from from Devan Unani Medical College. They are also doing laparoscopic surgeries. Dr. Sami Allah has commented also. He is also doing. Dr. M. Alam is also doing surgeries anywhere in laparoscopic surgery anywhere in India.
Okay.
Sir,
it is good to hear. And the answer for the person who asked whether the Unani surgeons are able to do it, so they are all doing it. The answer he got it most probably.
Sir, yes.
It is a basis. Is the basic thing is that you should be trained. Once you are trained, you can do it. Sure. And now government has got no inhibitions in performing any term of procedures if you are trained. Sure. If you are not trained, you should not do it.
Yes, surely, sir. Sir, it was informative, sir, regarding laparoscopic cholecystectomy, hernia repair, and the new thing we are not doing this renal surgery. The balloon is making the space, inflated balloon is making the space there. It was a new thing for us. And sir, one more thing, the coordination of hand and eye you told about, it is like, sir, I may add here, it is like a video game. Who is expert in video game?
Typical video gaming.
Who is expert in video game can perform laparoscope, can handle the this laparoscopic surgery easily.
Yes. The robotic surgery is the playing a video game. You are in the distant sitting and office and performing the surgery.
Yes, sir. Laparoscopic surgery is almost the same like who is expert in playing video game can do well in laparoscopic surgeries also.
Okay, yes.
Sir, I may, sir, add here, you told her Dr. Udwalia has done first surgery in Mumbai in laparoscopic surgery. If I am right, I remember that first laparoscopic surgery in Aligarh was done in Ajmal Khan Tibia College. It was started, laparoscopic procedures were started in Ajmal Khan Tibia College.
Yes.
If I am right, sir.
Yes. It was long back in 1996. There was no laparoscopic surgery in the Medical College. We started the laparoscopic, and I assisted the laparoscopic cholecystectomy in 1991. In 1990, it was started in Bombay, and I assisted the laparoscopic cholecystectomy in 1991 in Mohannagar, Ghaziabad.
Yes, sir. So we have chosen this topic because laparoscopic procedures has gained much popularity now among the masses, among the common man. Even the जब पेशेंट आता है ओपीडी में, एक आम आदमी वो इस तरह से पूछता क्या ये ऑपरेशन दूरबीन से हो जाएगा? The paradigm has shifted to this laparoscopic minimal access surgeries now. Now, dear audience, the session is open for your queries. You can ask relevant questions only. Sir is available. Sir is available for your answers. Any question from the audience?
Sir, I want to know one question.
Yes, Dr. Abubakar. Dr. Abubakar has some queries.
Abubakar, welcome.
Sir, Assalamu alaikum, sir.
Walaikum salam.
Sir, I want to know one question. You were asking about the three-dimensional advancement of the laparoscopic surgery in the form of three-dimensional laparoscopic surgery. I want to know one thing: how frequent this type of surgery, that is the three-dimensional laparoscopic surgery, that is being performed in India? How
It's very
frequent
common.
it is, sir?
It is very frequent. It is a matter of camera. You are having a 3D camera.
Okay.
And it has to be, it's very common, not a rare thing, that 3D. It's only the equipment. I have already said that it is only the equipments you are having. And it is easy to do a 3D surgery than two-dimensional surgery. But it's only that you should have a 3D camera. It's same as the laparoscopic 2D, but with 3 dimensions. It is easy to perform. It's not a rare. It is being performed.
Yes.
So one more query. Thank you, Dr. Abubakar. We have one more query from Dr. Sahi Bole Sohail. Sohail, are you there?
Sahi Bole. Okay. He is in Jamia Hamdard.
I don't know right now where he is.
Okay.
He has raised the query whether this cystic artery can be ligated with the cautery where, or is it necessary to clip it? Sorry, can it be cauterized? Sorry. Can cystic artery be cauterized only, or is it necessary to clip it?
It is necessary to clip it, because cauterization because it is an artery, cauterization produces the coagulative necrosis.
Yeah, correct.
And if it is coagulative necrosis, there may be secondary hemorrhage. Secondary hemorrhage chances are there. So it is important to clip it, so that if the end does not bleed, because in coagulative necrosis, there is chances of secondary hemorrhage.
Thank you, sir. Any other participant wants to clear?
Imtiaz, yes,
Dr.
welcome.
Imtiaz is there. Yes, Dr.
Assalam, sir.
Welcome, Dr.
Sir, I want to, okay, thank you, sir. Sir, I have also started laparoscopic cholecystectomy in my college here, and Alhamdulillah, we have performed 2 surgeries. Ji, Deoban.
Okay.
Yes,
हाँ, picture डाली थी, देखी थी मैंने.
Ji, and Alhamdulillah, I have purchased it my own.
Okay.
My personal set. It is second-hand one, and non-HD camera. I want to ask you one question, sir. If we are having harmonic scalpel or bipolar monocauterization,
harmonic scalpel
and bipolar cautery, so is it must to clip it in case of cystic artery?
मैं समझा नहीं मैं.
अगर सर हमारे पास हार्मोनिक स्कैल्पेल है और बाइपोलर कोटरी है, तो क्या जरूरी है वहां पे?
क्या जरूरी है? आवाज आना बंद होगी, म्यूट क्यों हो गए तुम?
सर ये पूछना चाह रहे हैं, क्या उसके बावजूद भी हमें क्लिप लगाना जरूरी है या हार्मोनिक से हम कॉटराइजेशन कर सकते हैं?
हार्मोनिक से
सिस्टिक आर्टरी
द सेम द
सर अगर हम ये करते हैं
इम्तियाज, आपकी आवाज योर म्यूट, आवाज नहीं आ रही आपकी।
सर अगर हम LABH में करते हैं या फिर टोटल लैप्रोस्कोपिक हिस्टेक्टमी करते हैं, तो in that case we don't apply any clip in uterine artery or ovarian artery. So why is it must to apply clip in case of lap poly in cystic artery?
In cystic artery
जी सर, वहां पे सर यूट्राइन आर्टरी को सर जब हम कर सकते हैं उसको बगैर क्लिप लगाए, एंड यूट्राइन आर्टरी हैज मोर प्रेशर एंड देन सिस्टिक आर्टरी एंड ल्यूमिनस वाइड देन सिस्टिक आर्टरी।
अच्छा, तुम्हारे कहने का मतलब ये है कि सिस्टिक आर्टरी को क्यों, बट आई हैव टोल्ड यू देयर इज chances of secondary hemorrhage.
Imtiaz, just I'm interrupting you, sir. Please allow me.
Yes, sure.
Yeah, Imtiaz.
जी.
Yeah, the gold standard you have to clip it the cystic duct, but artery you can coagulate. Artery you can coagulate if you have an harmonic scalpel. If you have an harmonic scalpel, but you have an M seal also. With the help of M seal, you can seal it, not cauterize. If you seal the cystic duct, you can seal it.
यूट्राइन आर्टरी में हम क्लिप क्यों नहीं लगाते सर? वहां पर हम यूट्राइन आर्टरी में हम क्यों नहीं लगाते? यूट्राइन आर्टरी while doing total laparoscopic hysterectomy वहां पर हम क्लिप क्यों नहीं लगाते हैं?
Because I will not be able to answer this question because I am not a gynecologist. It is to be asked by the gynecologists who are doing a hysterectomy. I am not doing hysterectomy too, so I don't have any experience of doing a hysterectomy.
Total laparoscopic hysterectomy are doing here. Sometimes we can coagulate the artery. No need to clip it the artery.
Yeah, they are regularly doing it.
Yeah,
they are regularly doing it by coagulation with a harmonic scalpel or with the bipolar cautery or by the sealer. They are using all three things to coagulate the infundibulopelvic ligament as well as the uterine as well as the ovarian pedicle. They are not using any clipping there.
Yes, sir.
The reason, I'm telling you the reason. They put the cautery or the harmonic scalpel till the whole of the tissue is necrosed. But in near the basic fundamental of cholecystectomy, you should not damage the hepatic artery, portal vein, common hepatic duct. If you produce, coagulate the structure there for longer period, then the heat dissemination is much more, and it produces the thermal damage to the surrounding structures and at the porta hepatis. Why you want to coagulate? When you are advised, the basic thing is that you should dissect the cystic artery, cystic duct, produce a window, separate windows for the artery and the duct, then the clip. Why you want to coagulate? To damage the structures surrounding the porta hepatis.
Yeah, correct, sir. So many hazards of artery.
Thank you, sir.
In doing the hysterectomy, there is no important structure which is to be damaged surrounding structure.
Sir, ureter is present there.
It's very far away. Very far away. If you are doing a hysterectomy and ligating the ureter, you are doing a blunder. It is very far away.
Sir, my second question, I have also one question. कि जो इस वक्त जो इंसफलेटर आ रहे हैं सर, अगर हम जो इंसफलेटर देखें तो देयर आर टू मोड्स प्रेजेंट इन दैट, वन इज फॉर CO2 and one mode is for air. Suppose during air, if during surgery CO2 is finished cylinder or something cylinder is not working, so can we use air? In that case, is it safe to use air mode?
It is emergency procedure. You can use the air. You can pump with the mouth. Pump with the mouth in emergency. You put the tube and pump the air through the mouth so that you complete your procedure. But I don't recommend the air as it contains the oxygen and you are using a cartridge.
Okay, yeah, correct. Few surgeons discourage it and they don't allow it as if we use cautery at that time, the air may cause burn there.
क्या कहना चाह रहे हो, समझ में नहीं आया?
अगर कॉटरी सर हम यूज करते हैं वहां पर एयर है तो कुछ सर्जन ये कहते हैं कि वहां पर आग लगने के ज्यादा चांसेस हो सकते हैं।
यही तो मैं कह रहा हूँ
जी।
तो एयर क्यों यूज करेंगे भाई? कार्बन डाइऑक्साइड रिकमेंडेड है। वी आर टॉकिंग ऑफ द आइडियल सिचुएशन, वी आर नॉट टॉकिंग ऑफ आवर प्राइवेट प्रैक्टिस। क्या अगर इंसफलेटर ने काम नहीं किया तो एयर भर दो पंप से और या कुछ और कर लो, ये कर लो, वो कर लो। इट इज नॉट टू बी डिस्कस्ड इन द वेबिनार। ओके,
okay, Dr. Imtiaz, now I hope you are satisfied with the answer. And I think this clip application is the safer side, always to be on safer side.
Yes, we have to clip every time. We have to clip. We don't recommend any cauterization. Not on the safer side. It is to be clipped.
Yes,
must to do. Gold
standard.
Yes, gold is the golden side. It is the safer side. So we will thank you, sir. Thank you very much, sir, for your time, for your and thank you for participants for patient hearing. And now we will start with our second lecture. Second lecture will be delivered by Professor Saeed Shah Alam, HOD, Department of Ilmul, Jarahat. Since he has joined this department from in 2012, tirelessly he has worked for the department, for the upliftment of the department. It is his guidance that we have been able to start operation theater and start up state-of-the-art operation theater here. He is actively engaged in the administrative works of department and the operation and the hospital. He has been deputy medical superintendent of the hospital for 5 years almost, and he is actively engaged with the NABH. He is also NABH assessor, and he has created many publications, and his research area is the non-healing ulcer, and he has a good hand in surgery, in laparoscopic surgery also. I will invite now Professor Saeed Shah Alam to deliver his talk. Professor Saeed Shah Alam.
Yeah. Assalamu alaikum. I'm audible?
Yeah. Yes, sir.
I'm audible.
Proceed, sir.
Today my talk is now first of all, thanks to Almighty Allah giving me the opportunity to deliver this talk on the laparoscopic instrument and their uses. And thanks to Dr. Sir to give me the opportunity to such type of webinar organized in the department of Jarahat, first time ever. And thanks to all the department colleagues and all the staffs. Now we will start and going to the start instrument, how you can judicially use so many armamentarium, so many instruments are using in the laparoscopic procedures. But some of the common instruments we are using in the context of laparoscopic surgery, now we are discussing. My brief content is especially we are discuss about the composition of the laparoscopy, but some description, general description in the history, principle of laparoscopy, whatever the basis. Now we come to the endoscope. The basic principle of the laparoscopy is based on the endoscopy first. The endoscopy purely non-surgical procedures. It allows to see the problem within our body without making large incision at the normal orifice of the body. So many type of endoscopy performed by the different type of surgeons, physicians, or just like arthroscopy, bronchoscopy, colonoscopy, cystoscopy, enteroscopy, hysteroscopy, and now my topic is about the laparoscopy and so many other type of the endoscopic procedures performed by the surgeons and others. Now come to the point, what is the laparoscopy? How you can say what is the laparoscopy? If anybody asks me the question, what is the laparoscopy, then you can define it. The laparoscopy is technically dependent surgery comprising of computerized designed instrument with microprocessor controlled safety features. Principle of laparoscopy is totally based upon the identification of pathology and surgical intervention. This would be the principle of laparoscopy. First of all, you see the brief history of the endoscopy. That is why we told that it is a development, evolution of the laparoscopy by the endoscopy. The Hippocrates era backs the exploration of the human body through small or natural orifices dated back to the time of Hippocrates. He described the use of primitive anoscope for the examination of hemorrhoid in 400 BC. But Arab physician Abulcasis added the external light source to see the inside source of the. That means first time the use of the light source in the endoscopy. The evolution of laparoscopy is based on the natural orifices. That means Egyptian observation of the natural orifices told by the advance in surgery channel in US. In 19th century, first endoscope built the external light source, and the 20th century internal light source, automatic insufflation, extension of different discipline, evolution of technology implemented in the laparoscopy. So many indications, but now some described here: the intra-abdominal indication, cholecystectomy, vagotomy, appendicectomy, colectomy, hernia inguinal, hernia ventral, hernia repair, nephrectomy, adrenectomy, spectomy. As told earlier, my mentor, Professor Iqbal sir, so many others. In gynecological procedure, diagnostic, fertility workout, trabectomy, ligation, ovarian cyst puncture, hysterectomy, and so on. But now the contraindication, you know about the contraindication. All patient is not fit for the surgery of the neither open nor laparoscopic. You have to know about the contraindication. How can evaluate the patient? In absolute contraindication, never do the laparoscopic surgery. Just like a generalized peritonitis, intestinal obstruction, clotting abnormalities, liver cirrhosis in case of failure to tolerate general anesthesia, uncontrolled shock, and some related contraindication also. That means multiple abdominal adhesions, organomegaly, abdominal aortic aneurysm. Now you see the armamentarium of the laparoscopy. So many big armamentarium. Majority of the instrument has been used in different type of surgical procedures with the laparoscopy. But now we have no much time to discuss all the instrument. We have to discuss some common instrument using and how you can judicially use the instrument in the laparoscopic port formation and other conditions. Now you see there's some common use hand instrument which is used commonly. We are day-to-day basis, we are using the Ireland forceps, monopolar hook, alligator, GB extractor, traumatic grasper, clip applicator, suction irrigation cannula, fine scissors, aspiration needle, so many types of procars and cannulas. I will discuss later. Procars you can use 3 mm to 15 mm. It depends upon the build, size, age of the patient, pediatrics, adult, infant, so many pediatric person. So you can, but majority of the common procar and cannula use 5 to 10 mm, 10 mm and 5 mm. In pediatrics, 1 to 3 mm. Majority of the procars conical, pyramidal, traumatic, atraumatic, blunt, conical, sharp, shielded, Hassan type, shielded type, and some optical nowadays using the optical, but it is a costly one. Now my topic is come to the composition of the laparoscope, how to use the laparoscope and what is the composition. So 5 compositions are there. One is equipment card, insufflating system, imaging system, instrumentation, and electrosurgical quality system. Now equipment card. How the equipment card show having a trolley and the brakes of the trolley having 5 portions almost. One is monitor shelf, one is a light source shelf, one carbon dioxide insufflator shelf, one electrosurgical shelf, one is stand for the monitor. Like show, this is a card from the NIM OT. You see the NIM OT, monitor stand, imaging processor shelf, carbon dioxide insufflator shelf, all these. Now, how you can insufflate? Insufflating system in laparoflator. This is very important thing. How much pressure it will be there, how much flow will be there, what are the ideal condition of the insufflator in your machine. So in insufflating system, you have the design and deliver the gas, only deliver the gas from the machine to the abdominal cavity or any other cavity where you want to do the surgery. So insufflation pressure can be set from 0 to 30 mmHg. This is a range of the setting. Gas flow volume can be set for 0 to 9.9 liter per minute. Majority of the surgeons don't know how to set the pressure of the abdomen and any other viscera where you want to do the surgery. So that is why this is very important to learn. Insufflation tube with 0.3 micron filter. Without filter, just earlier the told one person the question how you can not use the oxygen. So many things, oxygen is heavy, has a combustible, have inflammable. So many disaster may be provided with the use of the air or oxygen. Filter is recommended to prevent the contamination with bacteria, microparticles, and debris from the insufflators and gas tanks. Now, the ideal pressure should be 12 mmHg. In any circumstances, it should not be more than 18 mmHg of pressure. That is a very, 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 very important thing. When surgeons or gynecologists want to perform the diagnostic, the pressure should be 8 mmHg. In case of special situation, other surgery, axilloscopy, arthroscopy, you can increase the pressure up to the 19 or more than 19 mmHg. So what type of gas to use? I think the question in this, the gas used, the ideal and ethical gas should be used carbon dioxide. Carbon dioxide. And other gases are contraindicated, neither be mentioned anywhere to use. But in earlier stages, in primitive stages, when carbon dioxide is not validated for this procedure. So you can use a different type of cylinder. This is a NIM card to attach the cylinder. 2.5 pound, 5 pound cylinder, 7 pound cylinder, 10, 15, 20, 35, and 50. This is a 50 pound cylinder. Why carbon dioxide? The answer in this, why carbon dioxide? Why not oxygen? Why not air? Why not other thing? That means it is readily available. It is easily available in the market, low cost. Carbon dioxide is highly soluble in blood. So the gas embolism is rare. This is a very important feature. Highly soluble in blood, so the gas embolism is rare. Non-combustible, never still the fire. Rapidly buffered in the blood by carbonates and excrete via lungs. Carbon dioxide has same refractive index as air, so doesn't distort the image. Image quality should be better in the carbon dioxide other than the air and oxygen. So how do we connect the carbon dioxide and travel to the gas from the machine to the abdomen? So this tube is a connecting tube and carbon dioxide cable having a 2 ends. One end connect to the port of trocar, one end connect to the insufflator. And insufflator. What is insufflator? Surgical insufflator safety transport carbon dioxide to the patient body, most commonly the abdomen, to distend the working area and allow better access to anatomy and use of surgical tools. Pressure setting. How you set the pressure and what was the ideal pressure? 10 mmHg ideal for the patient. Beginners may not be comfortable because the abdominal distension is lesser. 12 mmHg is ideal for the patient and surgeon both, but 14 mmHg surgeon comfortable, not always safe. That means more than 14 is never safe. The safe pressure 12 mmHg or less. Now the third one is imaging system. Imaging system, imaging quality is better. Without imaging, you can't do the laparoscopic surgery. Without light, you can't do the laparoscopic surgery. The picture quality and light quality should be better. That means you have to know about the magnificent seven. That is one thing: light source, one fiber optic cable, one telescope, camera console, video signal processor, video cable, and monitor. If you don't have a single thing, you can't do the laparoscopic surgery. So magnificent seven, all 1 to 7 make to the imaging system. The imaging system is this. Here you see the light source first. First you see the light source. High intensity of light source graded with the bulb of halogen, xenon, mercury vapors. So 3 type of lenses light source are used: halide, halogen, and xenon. So there are some pros and cons of the different type of lights. Halogen is nowadays very lesser to use because it is very cheap and lower than the natural light. It is a yellow light. It is not a white light. So that is why the xenon is used. My OT is having a xenon bulb, and xenon is suitable light source, and it is like a sunlight. Sunlight having a 5800 Kelvin. That is natural white. So white balance you can maintain in the xenon, but can't maintain in the halogen white base, because the xenon having a 6000 Kelvin white balance, and that means more than the sunlight. So its image quality is better as a sunlight image you can see on the screen. So that is why it is a white light, halide and xenon, and halogen is the yellow light. So, but halogen is a cheaper, economical, xenon is a more expensive. So the light cable, how the light travel from the light source to the camera console and the telescope. The light cable having 2 types: fluid-filled cable and fiber optic cable. Now fluid-filled is nowadays obsolete. Nobody use of this fluid-filled cable because it is tougher. It is a heat tougher in nature. So there's a problem in the handling of the other instrument. They're difficult to autoclave. Now the fiber optic cable, they conduct less heat. They are soft and sound to handle. They don't produce the hindrance while handling the camera console. They are easily autoclaved. That is why you see the cable, the fiber optic cable having a 2 end, one end connected to the telescope and another end connected to the light. So you see the one fiber of the fiber optic cables, and you see how the light travels in the glass and the air and the light rays. Now the camera console. We discussed with the camera console. Now I'm discussing only the magnificent 7. This is a very better use. You know about the 1-chip camera, 2-chip camera, 3-chip camera. That is only 3 colors. The primary 3 colors are produced proper image: red, green, and blue. So first of all, in 1978 introduced the camera. The charge coupling device known as chip. It is an electronic memory that records the shades of 3 colors: red, green, and blue. 3-chip camera uses 3 CCTs, charge coupling devices, one for each of red, green, and blue. That is why the picture quality will be better in 3-chip camera. In single chip camera, all green, red, and blue recorded by the 1 chip only. So that is why you see the camera console. The camera console, the one having 2 end, one end connected to the video processor, as I shown earlier in the equipment card, and a telescope is connected to the telescope and another end, main camera console. Now the feature of the camera console, you see one camera chip contains 2.5 to 3.8 lakh pixels. So one camera having, for example, one chip having a 2.5 to 3.8 lakh pixels, but in having a 3 chip, that is multiplied by the 3. In single chip camera, all 3 colors are sensed by the 1 chip or 1 sensor. That means the quality will not be good. In 3-chip camera, the 3 colors, red, green, and blue, are sensed by 3 separate sensors, hence called 3-chip, that is charge coupling devices. The camera should be focused at 10 centimeter away from the 10 millimeter probe target. White balancing must be set for insertion into abdominal cavity. Now the telescope, endoscope or telescope, 2 types of telescope, rigid and flexible. British physicist Hopkins invented 1952. The rigid normal use telescope is 0 degree to 120 degree, but the best is used in the 30 degree because 30 it is the bevel tip forwarding 30 degree angle to 45 degree angle. So having a 3 features should be there. The telescope having a 3 features. 3 difference, structural difference: number of rod and lens, angle of viewing, and diameter. and diameter. Available for 6 to 8 rod lenses and 0 to 120 degree bevel tip telescope. Diameter available 1.5 to 15 millimeter, depends upon the type of operation and age of the person, age of the patient, and size of the trocar and cannula. Now, most commonly used telescope in terms of lens angle and diameter, thin lens and Hopkins rod lens. Hopkins rod lens is better than the thin lens. Thin lens cheaper. Hopkins lens is better. Hopkins lens quality of the picture shown very better, like HD, Super HD, 4 HD, and so on. But now the pictures quality will be better day by day advancement are there. The angle of view is 30 degree telescope provides the 152 degree. Viewing angle 152 degree when you are using the 30 degree telescope. If we are using the telescope of the 0 degree, you provide the 76 degree. So majority of the cases you can perform the surgery in 0 and 30 degree. But 30 degree is better. Diameter, the most commonly used diameter is 10 mm and provides greater light and visual field. Next common is 5 mm. That means the diameter should be 10 and 5 because the majority of the cases can be operated with the 5 and 10 mm port. So 10 mm port or 5 mm port, that means you have only 2 cameras is enough, 10 mm and 5 mm. Now you come to optics, how it works. When we are using the camera person should be as a surgeon, doing work as a surgeon. If camera person is not good, surgeon can't perform proper surgery within the time. So don't rotate the camera, any change in the position, reorientate immediately. 30 degree telescope need proper attention. Camera has to come back during instrument exchange. Camera person has to be dynamic, should maintain the vertical orientation. One thing I will show in the picture, you see in the picture the manipulation angle. You see the camera in the center and 2 instruments away from it. If you take an angle to one angle right, one angle left, make it 2 angle. That is known as azimuth angle. Azimuth angle is up to 30 degree one side and other side is 30 degree. That means it is up to the 60 degree. If 60 degree angle is there, you can operate very easily and properly. That means you maintain the ergonomics of the and position of the patient and instrument. You see in this azimuth angle, and one thing you see the right side and left side, right azimuth angle and left azimuth angle. If you less the angle is smaller the angle, then chopstick effect you can feel during the surgery. That means difficult to operate and take more time to operate. If you are giving the wider more than 60 degrees, then end-to-end effect, you can't reach up to both instruments to the target organ. So that is the difficulties. That means ergonomics is another chapter. If any time we have time, then we will discuss in any other program. Ergonomics during the laparoscopy, that is another chapter. You see the endoscope telescope as discussed, 10 mm telescope and 5 mm telescope having a Hopkins quad rod lens, 30 degree, one is both are 30 degree. And you see detail of this feature. One thing is connected to the camera console. I have shown you earlier, and fiber optic cable connected to the end of one thing metallic shaft and 30 degree bevel tip. Now the next thing is monitor. Monitor is nothing. Monitor is just like a TV you are watching at a home. Which quality of TV you can purchase, you can see the picture of that quality. It depends upon the camera quality, camera console. It depends upon all these things and lenses. Now trocar placement. How you can place judicially trocar in the abdomen? One method, 4 methods are there: closed method, open method, direct puncture, and optically guided. And optically. Close technique by the use of virus needle. You can use the virus needle. The virus needle technique you can prefer in the GA nowadays. Spinal you can give it in empty bladder, empty stomach, head down. With the ideal condition to perform in the GA. The virus needle side umbilicus, umbilical margin, below umbilicus, and the side light and lift of the abdomen, both side or center. Two position of the lifting of the abdomen, either both side or in the center. Virus needle technique is safe in experienced hand, and check the 2 things: spring action of the virus needle, it should not be blocked. Don't use a virus needle if spring action is not working. You see the virus needle, And the direction of the virus needle, you see in the last picture, towards pelvic perpendicular direction, 45 to 60 degree afterwards, obliquely perpendicular towards pelvis, no deviation. The qualities of the virus needle: 12 to 15 centimeter long, 2 millimeter in diameter. The spring-loaded inner stellate is positioned within the outer cannula. This inner stellate has a dull tip to protect any viscera from injury to the sharp outer cannula. The lateral hole on the stellate enable to carbon dioxide gas to deliver into the abdomen. Now, how to check? Feel too resistant. When you insert the virus needle into the abdomen, you feel two resistance. One as a rectal sheath and the other peritoneum. Palmar test, you can done it. Aspirate, look for the vascular or bowel content. Inject saline, feel the resistant, and look for free flow. Re-aspirate, look for the free flow. Needle misplacement common is in between rectal sheath and peritoneum sometimes, because peritoneum is a stretchable organ. So one virus needle should not be moved inside the abdominal cavity. It is in cavity too much. Otherwise, there is a risk of laceration of bowel to puncture. Irrigation test and 10 ml with the help of 10 ml syringe, 5 ml normal saline, you have to inject it. Otherwise, you see the resistance. So aspiration test, irrigation cannot be sucked. If irrigation water cannot be sucked, that means aspiration test is good. Note, if the pre-peritoneal space or in the muscle fiber or above or rectus, injected water can be aspirated back very easily. More fluid is coming. If you aspirate the abdominal fluid, more fluid is coming out. That means there may be ascites, that means cyst, and sometimes fecal matter comes out if you are moving, if you are punctured the abdominal intestine, or if you are moving more of the virus needle. Sometimes perforation or laceration of the bowel, and fecal matter comes out, or sometimes blood comes out, that means the vascular injury. So don't remove the virus needle on that time, and urgent laparotomy is required. To find out the punctured area, why you don't remove the virus needle, that means you have to find out the punctured area after laparotomy. Further bleeding will be less. And another test you can perform another test, hanging drop test. In case of virus needle, few drop of the saline poured over the virus needle, abdominal wall, and virus needle lifted upwards. If virus needle inside the abdominal cavity, the hanging drop should be sucked inside. That means your position of the virus needle is in proper position. The creation of pneumoperitoneum, you have see it, and I'm explaining how you can assess. Now you see the in this picture, the ideally and judicially how you insert the virus needle. First you check with virus needle, there tape, there is spring, everything is not blocked. Then virus needle hold like a dart. First thing, very important, virus needle should be hold like a dart. Second is lift abdominal, lower abdominal, either bilateral or centrally. Direction of the virus needle is the perpendicular first, then goes to the abdominal wall towards the pelvis. Irrigation test, as I told, irrigation test and hanging drop test and other. Then beginning of insufflation with careful hold over virus needle. So this is how you can use the virus needle, how you can less the hazards, how you can less the complication of the virus needle insertion at that time. When the problem due to pneumoperitoneum, sometimes hypothermia, cardiac arrhythmia, cardiovascular collapse, pulmonary insufficiency, gas embolism, venous thrombosis, cerebral edema, ocular hypertension, and extraperitoneal insufficiency or emphysema. Now come to the open technique. This is the closed technique. Now come to the open technique, how you can perform duration. About 12 to 14 mm incision is given supra or infraumbilical region inside the skin. Identify the rectus sheath. Lift the rectus with Ellis forceps. Incise the rectus sheath. Identify the peritoneum. Open with scissor. Introduce your finger inside. Confirm the entry. Introduce procar. Inflate the abdomen with carbon dioxide. And sometimes with difficulty producing the gas leak, then in the open method, so that time you have to use the persisting suture in the rectus sheath level, occlusion with the towel clip, or occlusion with the Ellis forceps. So many difficulties may be there. Precaution in open technique, no rapid pneumoperitoneum and flow rate less than 3 liter per minute. Now the instrumentation. Come to the trocar. How you insert trocar? As you all of you know, one trocar, one sheath. Sheath without trocar, without cannula, you can't do the laparoscopic surgery. Trocar are placed to the abdomen during laparoscopic surgery. Uses of trocar is a function as a portal, making a port. Their subsequent placement of other instruments such as grasper, scissor, staplers, etc. Now you see different type of 5 mm trocar with cannula, 10 mm trocar with cannula, essence trocars with cannula. That is a traumatic, blunt, sharp, so many types. Why the primary port making at the infraumbilical? Why? You see the pictures. You see the everybody knows the anatomy of the anterior abdominal wall, and use a different type of cannula and sharps, conical and pyramidal, blunt. Why we are using the infraumbilical? Because there is fixed peritoneum. There is a thin layer. They're very easy to introduce the trocar and least vascular area and good cosmesis after surgery. Now, angle of insertion. How you insert? How you insert? You see the graphic presentation and the pictures, real pictures. So initially, angle of insertion for primary trocar should be perpendicular to the abdominal wall, as shown in the graphic. You see the inside, the position of the anterior abdominal wall and the trocar and cannula should be perpendicular to the abdominal wall. But once surgeon feel giving way sensation, the trocar should be tilted to 60 to 70 degree angle. So always you hold the trocar and cannula is like a pistol, where you in the varus needle you hold like a dart. Direction of the trocar insertion as shown in the graphics, perpendicular to the abdominal wall. Okay. And other nowadays is a very latest condition in the busy port. Safe insertion of the primary trocar. You see another guideline is the green top guideline. At the time of first of all, you have introduced the pressure 20 to 25 should be achieved before insertion of primary trocar of the 10 mm. The trocar should be held like a holding gun with the index finger extending by the side of it. Once the trocar has pierced the peritoneum, it should be angled toward the anterior pelvis. Never direct insert. Either you puncture the, either you injure with the omentum or intestine or the aorta. The distension pressure should be reduced 12 to 15 mg after insertion of trocar. That means you come to the normal level of the distension after insertion. You see in the picture bilateral holding of the abdominal wall. They introduce in the lesser pressure. You injure the internal organs, and you see the 20-25 mg pressure. You don't injure the internal pressure initially. Some types of reducer are using to reduce the size of the trocar, cannula. This is the plastic and type of metallic, one sheath-like structure. This is our NIM laparoscopic reducer to reduce the size. You see the open method. As I earlier told you, first you incise 12 to 14 mm incision with the skin, subcutaneous tissue, and the anterior rectus sheath, then the rectus muscles, then the posterior rectus sheath. Now the busy port is expensive. Cost is a factor. Otherwise, it is safer. It is safest. you can enter into the abdomen with the direct vision over the screen. You see the screen layer by layer. You introduce into the abdomen. Pneumoperitoneum is not required. Pass through under vision. Under vision, you can enter the see through the all layers of abdomen. You can avoid any injury. Even it touches the bowel, will not injure. Cost is the main factor. And the advantage of the short of time, safe, easy to do, easy to repeatability, and problem which is very costly. But mostly patients don't mind for spending of the rich person. Now come to the another guideline, insertion of the another port. First primary port, then we want to go for the another port. Then how you can insert the trocar and cannula to maintaining the secondary and tertiary port. Secondary port are inserted under direct vision of endoscope. At right angle to the skin and 12 mg pneumoperitoneum. Once the trocar has pierced the peritoneum, the trocar should be drawn up and only sheath should be pushed further. And inadvertent injury from the secondary port could be considered as negligence. The trocar should be held like a holding gun, as I earlier told. You see here, accessory port placement, a secondary port placement under vision. First placement given by the either open method, either closed method, either the sharp or the blunt, but secondary port or tertiary port always made by the sharps. Avoid epigastric injury. So what should be in the mind? You are making the secondary port. Avoid should be epigastric injury. Avoid bowel damage. Place in comfortable position. Decide whether need 5 mm or 10 mm trocar. It depends upon the condition, depend upon the type of operation and surgeon's skill. To avoid the injuries, 3 things should be required. One thing, transformation, as shown in the picture. First, transformation. So what transformation show? As per where the wheel appeared, where is the epigastric vessels, and third thing is abdominal zone. The abdominal zone identification is the very must to introduce the accessory trocar placement. You see in the next pictures, you see the abdominal zones, which is a very important thing, abdominal zones. You see the picture, there is a pubic tubercle, pubic symphysis, you see the one diagram is 5 centimeter away, one is the 10 centimeter. 3 zones I am divided in the abdomen for the trocar placement. Zone 1 from midline to 5 centimeter. You see the midline to 5 centimeter. And you 5 centimeter to 10 centimeter. And you see the zone 3 beyond 10 centimeter. That means epigastric vessel, you see the epigastric, inferior and deep epigastric vessel, superior epigastric artery, superficial circumflex iliac artery, all these vascular structures runs in zone 2. That means zone 2 is a very dangerous zone for the bleeding after the operation, during the surgery, during the port formation. So avoid zone 2 for placement of the secondary trocars, the secondary cannula insertion. You see the undervision. Undervision you see on the screen. If you are inserting insertion of the trocar insertion under the vision, we appear the wheel and direction away from the internal organs or structures, and where you when enter the sharp, the sharp becomes out and push the only cannula. You see here 3 cannula in the downside. Last picture you see the 3 sheets are visible, and the first picture how you lift up and introduce the trocar, and you see the positioning of the trocars. Now they come to the needle holder. Majority of the persons never use the stitching either in the bariatric surgery or other surgery. They use the surgery. They very one required very skillness and training for the internal suturing. But the thread size is not more than 20 centimeter. Otherwise, this looks like a web of hairs in the abdomen. Sometimes they're knotting. Sometimes other not more than 20 centimeter at the time of stitching. Knot and knot pusher you can market is readily available to the sterilized Florida's knot, press knot are available in the market, but you can tie in the in your OT, you can make in the OT and perform. And one another thing, laparolift, any gasless laparoscopic surgery. Gasless laparoscopic surgery. It is a specialized surgery, not a routine surgery. It is a specialized laparoscopic surgery for the cardiopulmonary compromised patient. That means there is no contraindication of the pneumoperitoneum. On those cases, having a contraindication of the pneumoperitoneum, you can perform the gasless laparoscopic surgery. Sometimes it is purely gasless, sometimes it is hybrid, but majority of the surgeons are using hybrid. In hybrid condition, you have to inflate the abdomen up to 6 to 8 mmHg, not more than 8 mmHg, because it is a contraindication of the pneumoperitoneum. Why it is due under the GARA, no complication of carbon dioxide, and disadvantage post-operative pain and space not adequate. You see the gasless laparoscopic surgery, no added advantage of the other laparoscopic surgery, except if patient is high risk of pneumoperitoneum. It is known as abdo lift procedure. Now, so many other common instruments are using in the during the laparoscopic surgery, that the handling devices. Handling devices had a certain feature should be there. Certain features should be there, like you see the ratchet of the locking, rotator attachment of the electrosurgical cord, tape insulated or outer tape. 2 types of instrument. One is assemble, one is disassemble. कुछ जो है जो आप डिटैच कर सकते हैं, कुछ को आप डिटैच नहीं कर सकते हैं. ये डिपेंड करता है आप कौन से परचेज करें. What should be the good quality? Good quality, that means not less than 30 centimeter long. Jaw should be atraumatic. Disassembly or reassemble instrument you are using. Interchangeable. Sometimes you use the scissor. Sometimes you have used the Maryland one instrument, only one sheath only. Cleaning and sterilization. all the equipment of the laparoscopic instrument not sterilized usually by the Cydex or any other thing. It is the best thing. Ideally, you can do the ETO, ethylene oxide sterilization. Without ethylene oxide sterilization, it is not purely sterilized. Simple design, the minimum number of hinges and holes. Now come to the scissor. I'm not discussing the detail of the scissor, but types of scissor I have mentioned here where you want to use. This is a straight scissor, widely used straight scissor, control depth of the cutting. It is a lower jaw is fixed and upper jaw is moving. Now the another type of scissor, curved scissor, most widely by the curved scissor. Now you see the serrated scissor, prevent the tissue to slip. That is the advantage of this, prevent the tissue to the slip and cutting a slippery tissue or ligature. Now the hook scissor, it is C-shape hook. It encircles the structure before cutting. Tissue is held between the jaws and there is no chance of slipping. The hook scissor is especially useful for cutting secured duct or artery in laparoscopic surgery. So many types of scissor. Micro tip scissor. You cut the duct partially to facilitate canalization. Cutting the cystic duct for performing intraoperative cholangiography. Exploration of a small duct like common bile duct is very useful with micro scissor due to its fine small blades. Now you see the harmonic scalpel. You can use the harmonic scalpel for cutting, automy, cutting and coagulation. Everything can be performed with the harmonic scalpel and MC. This is the MC. You can seal it the duct as told the question earlier. With the MC, you can seal it with the help of ultrasonography. USG. Now the advantage I don't discuss with this advantage. Now come to the grasper. Grasper is nothing, is a normal instrument I'm using with the open surgeries, but having a long handles and jaws and everything. Straight fenestrated, Ellis grasper, maxi grasper. You see the straight fenestrated grasper, Ellis grasper. You see the maxi grasper, the tooth grasper. You see all the instrument like a open instrument, but only handle is long. You see the cobra grasper, you see the bowel grasper, you see the Babcock grasper. Now the Maryland dissector. Dissector, so many type of dissector. Maryland dissector is very common dissector, having a different curved and straight. So straight is a straight and curved having a 70 degree, 30 degree, 45 degree, 90 degree, 90 degree. So many type of dissector as wished by the surgeon. Watch whatever the procedure here is performed. They are doing using the dissectors. Maryland is a commonly used dissectors and an instrument inserted by the 5 mm trocar with the help of reducer or direct into the 5 mm trocar. Dissectors comes with long curved jaw and fine crab tip. Dissector used mainly for separation of sac and cord dissector. As Professor Iqbal sir shown you the picture, the dissection of the cystic duct and cystic artery is shown with the help of Maryland and fenestrated grasper. With the help of this process, dissected very easily. Also use the other blunt dissecting purposes, rotating shaft to allow easy dissection with lesser strain. You see here, you see tissue stripping and dissection. You see the cystic duct, they are dissecting with the help of Maryland and gallbladder is upside. Now clip applicator. You see the clip application in earlier video shown by the professor sir. So you see that this is a titanium made clip. It is a metallic clip used to pressure and handle the instrument. There is 4 type of clip: small, medium, large, and large. 4 size of clips are available in the market. It depends upon the size of the duct and size of the whatever you want with the help of clip applicator. So many type of clip applicator available in the market. This is our OT clip applicators. So you see the pictures above. There is a 200, 300, and 400 size of the clip applicators jaws. You can use with the help of clip applicator. Fix it and then apply. You see the picture. The applying of the clip with the help of clip applicator, and the middle picture shown the cutting with the help of curved scissor of the cystic duct. And a suction and irrigation camera. This tube is essentially used in case of intra-abdominal leakage in order to clear out of the affected area. This is 3-way cannula in which one end is used for suction and other for irrigation, and third one is being placed to the abdominal cavity as shown in this picture. There is a different port for drainage and one port for irrigation, and another is a tip in the abdominal cavity and thumb control. You have the suction and irrigation with the help of thumb control. 5 mm and 10 mm according to your size. Now the electrical surgical cartridge system. Electrical surgical cartridge system. So, without cartridge, it's very difficult to operate, and good quality of the cartridge should be there. The electrosurgical cartridge is the application of the high frequency. So many type of monopolar cartridge, bipolar cartridge, so many type of probes you have, monopolar, bipolar, harmonic scalpel. Frequency alternating polarity, electrical current or biological tissue as mean to cut, coagulate, desiccate and tissue. In electrosurgical procedure, the tissue is heated by an electric current. You see the different type of pottery hooks and spatulas. There are so many type of hooks and spatulas, well designed. It can be wide, flat, pointed. So many types of there. It depends upon the type of surgery. You see the name of the different ends. What is there? The two type of I'm showing here. One is wide, one is fine. So hook tip for the dithyramide dissection, insulated shaft. It is very must to before introduction of introduce the hook into the abdomen. You see first inspect the instrument and see the any wear and tear. Otherwise, so many hazards will be happen, and after the completion of operation, you have very confident. I have done it very properly, but afterward the complication happens due to hazards of the pottery. And the other end attached to the pottery cable. Pottery cable is look like this. This pottery cable, one end attached to the electrosurgical cable and other connected to the generator during the process. So monopolar, bipolar, and bipolar is the safer, and monopolar you can use, and best safer side is scalpel, harmonic scalpel. Hazards of some 2 or 3 hazards I'm showing here. Hazards of laparoscopic dithyramide use burning wrong structure, misidentified anatomy. First thing, you know the anatomy of the structure, you know the anomaly of the structures. Either you are operating the gallbladder, you have know the anomaly of the gallbladder, you know the anomaly of the cystic duct, you know the anomaly of the cystic artery, you know the anomaly of the CBD. So inadvertent activation of electrode out of view, without knowing you are pressing the pedal either green or blue, yellow or blue. High current density in pedicle, residual heat on instrument, current leakage, bowel burn, jerky movement. If anything injured in the bowel wall, there is jerky movement of the abdominal wall, thermal burn around the trocar if insulation is not proper. You see here insulation failure. You see as I told you earlier, there is a pottery hook. If any wear and tear, for example, insulation damage is there. 5 mm instrument you introduce and you go to the target organ for the dissection or coagulation. But current also reduced from the insulation damage. You damage the bowel or any other part of the abdomen. That is should be hazard. And other thing, direct coupling. You touch to the another instrument anywhere, and then direct coupling, and burn to the another side. It's very cautious. That time we are using the pottery machine. That is why the bipolar is a more and more safer. You see the capacitive coupling injury. You see the capacitive, that means the outer sheath made up of the plastic sleeve. You are using the disposable trocar and cannula having a plastic sleeves, and you are using like the current should be discharged in the plastic cannula. Better you have to use the harmonic scalpel. And now we come to the different positioning. So many other instruments are there. Thousands of instruments depends upon the procedures. So all instruments having no time to discuss here. Now we will show some positioning of the port position of the diagnostic laparoscopy and the port position of the cholecystectomy and port position of the and position of the bilateral gynecological procedures. You see the use of instrument, how you're using the instrument. There is clearing adhesions by hook. You see the first, second, third, fourth. So one is fenestrated instrument, hold the momentum, and second is the cautery hook. And with the help of cautery hook, and the fourth picture, you show the adhesions gradually released. How you show this completely released. Or now we are using the Maryland forceps and fenestrated forceps. In Maryland forceps, make a window and creating a window, identify the callus triangle and make a window and de-skeletization of the callus triangle. And the clip application with the help of clip applicator and scissor, everything we have to use. And now we are using all the instrument, cutting, coagulation, and the extractor. Now we use the extractor, gallbladder extractor, and we hold it and extract it out. Gallbladder, appendix, whatever the organs, you have to dissect it, and you have to remove with the help of dissector. So majority of the common instrument I'm discussing here, because we have a limitation of time. So now we have concluded all these instrument, how you judicially use, and the main thing, how you can pneumoperitoneum, create the pneumoperitoneum. That is a very, very important, either by the closed method or open method or by the VisiPort or the VisiPort. And how you can use the angle of the instrument, how we can the judicially use of the angle, port position, where you make port position, where you are not making the port position, whatever the accessory port, where you make the accessory port. So this more benefit of this talk only for the how you can use the instrument judicially, and how can you use the judicially for the electrosurgical cautery unit. We are very frequently use the electrosurgical cautery unit, but we don't know about the hazards. So that is why I think majority of the person see all these things and listen me properly. If any question, anybody can ask the question. And now I'm concluding. Surgery, like a truth, is hard but cures.
Thank you, sir. Thank you for your valuable information about the instrumentation of the about the laparoscopic instrumentation and their uses. It has been very fruitful for us to know about the various instruments and how we have to use them judiciously during the procedure. And we came to the conclusion that we must know about the instruments very well, so we can use them carefully during the procedure, and we may not face any trouble during the procedure, as the question was earlier raised by Dr. Imtiaz. And Dr. Now, simultaneously, we must know about the anatomy of the abdomen also, and anatomy of the human body to use and where and how to use these instruments. So you have clearly and minutely explained the instruments and their uses. Almost you try to cover each and every instrument which are used during the procedures. Thank you very much once again. Dear audience, sir is available with us. You can put your queries. If you have any doubts, he will answer your queries.
Sir, I have question.
Yes. Yeah, Dr. Abubakar, welcome.
Assalamu alaikum, sir. Sir, I want to know one question. Sir, while doing laparoscopic surgery, on the monitor screen, the whatever the content of the abdominal cavity that are shown on the monitor screen, the color of images are different. They have changed color resolution when compared to when you see the structures in open laparotomy, and the color that you see, that is totally different. That are the natural color, but you see the structures that are being shown on the monitor screen.
Okay.
The monitor screen that has different color resolution, that makes the difficulty in differentiating the neighboring structures.
Yeah.
And especially in the smaller ones that you can miss is there any technological improvement that can bridge such gap and that can make structures that more vivid, more natural, and that we can easily identify? Is there any technological improvement that can bridge such a problem?
Yeah, that is why I already can discuss it. Earlier, we are using the halogen light. It gives me the yellow image. Now I am using the xenon or halide bulbs. So in that cases, you have the improvement like a more than the sunlight. I told you earlier, the sunlight having the 5,800 Kelvin natural white balance. I think you got it, my point. But in xenon and halogen, xenon having a 6,000 Kelvin, more than the sunlight white balance. That means if you are open the abdomen in the open laparotomy and the laparoscopy, you have seen the same pictures, and sometimes it's very better quality than the open surgery. And it also depends on magnificent 7, what type of your laparoscope and what type of a telescope, what type of a camera console, and what type of a monitor. For example, you are using the simple monitor, where you are using the HD monitor, you are using the 4HD monitor. Now the latest camera is coming to the, you can coding the color code of the lymph nodes and cancer cells. Now the new camera is introduced, I think 3 or 4 months back. It is in the crore. So it is depend upon the technology day by day improving in this condition. And now it is, I think there is no problem in the clarity. As a small minute thing you can't identify in the open surgery, you can identify in the laparoscopic surgery on the screen, and depend upon the size and quality of the instrument and equipments and your technology, which technology you purchase. Okay.
Okay. Thank you, sir.
Thank you, sir.
I may add here the picturization sir has used it in his presentation was almost real from our OT setup. He has used our own OT instruments to explain the instruments for you. Any other participant wants any clear his any doubt?
अस्सलाम वालेकुम सर।
वालेकुम सलाम।
सर मैं ये पूछना चाह रहा हूँ, अगर एब्डोमेन जब हमें क्लोज करना है गोल ब्लैडर आउट करने के बाद, तो कैन वी क्लोज इट इन अ सिंगल लेयर और दे इन डिफरेंट लेयर्स? मतलब सिंगल लेयर में एक सिंगल स्टिच लगा सकते हैं वहां पर सिल्क से, या
नहीं? आप ओपन सर्जरी की बात कर रहे हैं, लेप्रोस्कोपी की बात कर रहे हैं?
लेप्रोस्कोपिक। और एक मैंने बहुत सर्जन्स को देखा है जो कि नायलॉन से या सिल्क से सिर्फ एक सिंगल स्टिच लेते हैं, वो वहां पर एक ही सिंगल लेयर में सारी लेयर्स को वो ले लेते हैं। लेकिन जो हमारे कॉलेज में होता था, अजमल खातिबिया कॉलेज में, तो वहां पर जो है सर वगैरह जो करते थे, वो जो रेक्टस है वो सर अलग से वाइट से लगाते थे, वो उसके ऊपर सिल्क से लगाते थे। विच वन इज बेटर?
चलिए, ओके, देखिए ऐसा है कि 5 mm पोर्ट अगर है, there is no need of stitch inside, only आप stitching If 10 mm port, there is a need of stitch because of the complication. Hernia is a major complication, or mainly in the umbilical port. So there is a need of to minimize the port size up to the 5 mm in the ideal condition mentioned in the books. And I am using here one suture material available in the market known as port closer. You purchase the port closer and need to minimize the space any lesser than the 5 mm size of the port. Otherwise hernia will happen. तो उसमें जरूरी है कि आप स्टिच लें. Mandately you have to stitch the linea alba or peritoneum where you make a port.
Okay, thank you, sir.
Thank you. Is there anyone else to ask any question? Okay, sir. Thank you very much, sir, for your.
Hello.
Yes. Hello.
Am I audible, sir?
Yes. Please. Hello.
Not audible.
Hello. Yes. Hello. Kindly unmute yourself, sir. If you want to ask anything, please unmute yourself. Sir, you are not audible. Sir, please unmute yourself.
Hello.
Yes.
Am I audible, sir?
Yes, yes, you are now audible.
अस्सलाम वालेकुम।
वालेकुम
मैं ये
अस्सलाम।
चाह रहा था सर, जो अभी कोलिसिस्टेक्टमी के बारे में और लेप्रोस्कोपिक हिस्टेक्टमी के बारे में बातें हो रही थी, मैं उस वक्त बात करना चाह रहा था लेकिन कर नहीं पाया। मैं कहना ये चाह रहा हूँ सर कि इसमें जो सिस्टिक आर्टरी होती है वो शॉर्टेस्ट होती है और जो यूटेराइन आर्टरी होती है वो लॉन्गेस्ट होती है। आर्टरी का नेचर होता है श्रिंक करना और जो लॉन्गेस्ट आर्टरी है वो लंबी दूरी तक श्रिंक करती है और उसमें क्लॉट बनता है, इसलिए वो बगैर लाइगेट करे भी नेचुरली वो हील सील कर जाता है। लेकिन जो सिस्टिक डक्ट है इसके नीचे जो प्रेशर है वो काफी हैवी प्रेशर है और जो सिस्टिक आर्टरी है वो बहुत लो प्रेशर पे है और बहुत छोटी आर्टरी होती है, इसलिए उसमें जो है क्लॉट बनना और श्रिंक करना ये प्रोसेस बहुत ज्यादा इफेक्टिव नहीं होता। इसके लिए उसको सर जो कह रहे थे लाइगेट करने के लिए, लाइगेट करना ही और क्लिप करना या क्लैंप करना ही जरूरी है। बस इतना सा तर्क मेरा है सर।
जी आपने जो
सिस्टिक आर्टरी को लाइगेट करना जरूरी है।
हाँ, क्योंकि सिस्टिक आर्टरी इज वेरी इंपॉर्टेंट, इसके नियर बाई बहुत ही इंपॉर्टेंट स्ट्रक्चर्स होते हैं। छोटा हेपेटिस है, हेपेटिक है, राइट हेपेटिक, लेफ्ट हेपेटिक। तो अगर वहाँ हम कॉर्टरी का यूज करते हैं तो चांसेस ऑफ जो कैपेसिटिव कपलिंग है बहुत सी हजार्ड, अगर कोई हजार्ड हो गया तो आपका और लीकेज के चांसेस भी ज्यादा है, बाद में अगर प्रेशर बढ़ता है वो लीक हो सकता है। तो इस वजह से वहाँ हम जो इम्पोर्टेंट स्ट्रक्चर्स है उनको सेव करना है और फर्दर हमारी दूसरी कोई कैपेसिटिव कपलिंग हो गई, कोई और कपलिंग हो गई, जो हैजार्ड्स हो गए तो उस वजह से डैमेज के चांसेस ज्यादा है अगर कॉर्टरी यूज करेंगे हम सिस्टिक आर्टरी में। मेजॉरिटी ऑफ द केसेस जब जुडिशियली है और एथिकली है, जो बुक में मेंशन है वो एवरीथिंग इज यू हैव टू क्लिप इट। ओके, थैंक यू।
Okay, thank you. Thank you, sir. Almost it is over now. There's no query now from the audience. Thank you very much for your informative lecture. Dear audience, feedback form will be sent to you. Remember that your e-certificates will reach you after submitting the feedback form only. And inshallah, we will be back with the next session, next version of this webinar soon with you. Before leaving, I will invite Dr. Mahjabin Fatima, present vote of thanks. Dr. Mahjabin Fatima.
Thank you. Assalamu alaikum. Am I audible?
Well, yeah. Walaikum assalam. You are audible.
Assalamu alaikum to everyone. Honorable Director, NIUM Bangalore, Professor Abdul Badool sir, respected HOD Department of Ilmul Jarahat, NIUM, Professor Sayyid Shah Alam sir, respected Speaker Professor Iqbal Aziz sir, Chairman Department of Jarahat, Ajmal Khan Tibba College, AMU Aligarh, and all the respected participants. I, Dr. Mahjabin Fatima, Assistant Professor, Department of Ilmul Jarahat, NIUM Bangalore. I extend my gratitude to our Honorable Director, Professor Abdul Badool sir, for giving the support and encouragement to organize this webinar. A special thanks to our speaker, Professor Iqbal Aziz sir, Chairman Department of Jarahat, Ajmal Khan Tibba College, AMU Aligarh, for enlightening us with his profound knowledge and despite of his busy schedule. I extend my gratitude to our HOD, Department of Ilmul Jarahat and NIUM Bangalore, Professor Sayyid Shah Alam sir, for sharing his knowledge of laparoscopic instruments and for providing immense support to make this webinar successful. I must thank the organizing team for working hard from the past few days to make this event successful. I would like to thank all the participants for their presence and enthusiasm and for giving the valuable and encouraging comments during the webinar. Thank you everyone once again for making this event a great success. Thank you.
Thank you, Dr. Mahjabin. Thank you, everyone. And thank you, ITCL NIUM, for supporting us and for providing this online system amicably. Thank you very much. Thank you, everyone.
Thank you, Shukriya.